intact. Just got a message that the recording is in progress, so I guess that means we can go on. It's great to be able to talk to you about TMS. Many of you are familiar with it, know about it, but I thought I would take this opportunity to bring everyone up to date on what transcranial magnetic stimulation is about, and particularly the interface with psychotherapy, which I find to be particularly interesting. And also, since I'm kind of a believer in background and knowing some, having some depth of understanding, give you at least some sense of history about this and my own personal background, but also organizational background that led to this becoming a treatment. And as you can see with the current slide, the spoiler alert is that TMS is effective, safe, and durable. I'll give you some information about that, but also there is an addendum to this spoiler alert that we'll get to a little bit later. If we could go on forward to the next slide. Thank you. As I was preparing for this, one of the things that struck me, particularly in the context of talking with folks from National Psychotherapy Institute, is the importance of psychotherapy, and then what is that interface between this technology and our more traditional treatment, specifically psychotherapy. When I was a senior resident at Vanderbilt, I was the senior resident at VAPOC, the Vanderbilt Adult Psychiatric Outpatient Clinic, and Jim Nash was the attending there. And a couple of things. One, Dr. Nash made a comment one time I thought was very interesting, but as an analyst, we were talking about the training and what he did. And he was talking about the evidence that we had then about the changes that an analysis did in the brain, which was really interesting. When I was a medical student, I spent some time with a neuropathologist named Manny Stadlin, and for about 9 months or so doing some research with him and looking at nerve fibers and brain tissue. And at that time I was looking at this electron microscope, trying to understand what was going on. And then here's Dr. Nash as an attending telling me that there's this potential for brain change with the analysis. And during that 4th year in residency, I had the privilege and opportunity to work with Dr. Strupp as he was pulling together this book. And I pulled my copy of the book that you can see on the screen. And next to that on the screen, it's blocked out because of the gallery view for me, and I don't know if it is for everybody, but I found an envelope that I used to use as a placemark while I was reading the book. And it's actually an NPI invitation or information coming with presenting Steve Holland, who had recently come to Vanderbilt and to talk about cognitive behavior therapy. And so 35 years plus later, you're now all invited to see Dr. Holland present. But I thought y'all might be interested just in seeing that and putting it in some context. So I'm going to give you kind of 3 timelines of chronology to bring this up to where we are today. And the first one is just a bit of background on me. After residency, I went into private practice, which when that happened years ago, everybody started hospital work, had an outpatient practice and so forth. And my first office was at Medical Arts Building, which gets to be a little bit key in a bit. Later on, moved on to over towards Centennial Hospital. And then if you'll go to the next slide, about 20 years ago, moved into my current office, which is where I am now. And along the way have done inpatient work and outpatient work. And we can go, there you go, stay there for a little bit of time. And then a couple of contemporary stories that are correlated to my own professional journey. In about 1987, I was referred a patient who was a student at Vanderbilt at the time by the Oxford House Counseling Center, which was right next door to the Medical Arts Building, and why I knew them because of the proximity. And this young lady was struggling with her perception of not doing well in school, even though she was making straight A's, and had a lot of anxiety about her exams, but she was also dealing with depression and some obsessive thinking. There was a great deal of severity to her situation. And over the years, I continued to see her, and at one point referred her to Menninger back when it was in Topeka, Kansas. And they did some good work there, but continued to have concerns. And in mid 90s, I referred her to the Institute of Living in Hartford, Connecticut, where they were doing a lot of work with her, and she decompensated. And they referred her to McLean Hospital in Boston, part of the Harvard system. And then when she ended up coming back to Nashville, and the very bright lady, and she knew I would be interested, so she told me about the research that was going on there. And there was this gentleman named Dr. Alvaro Pascal-Leone, who was doing this work with something called transcranial magnetic stimulation. And this was the mid 90s, not the time when I could Google something and find out what it was. But it was intriguing as she described it, this way they were using this very high-tech magnet to create some change and help with symptoms. Well, from that time on, when professional literature would come out and there would be an article, I would pay attention to it. And this young lady continued to struggle. I continued to see her. She was on a number of medicines. She ended up, after her time at McLean, she was referred to a guy at Harvard named Tom Ballantyne, who was a neurosurgeon, and he did singulectomy with this young lady, which was a laser-guided procedure to address some of the parts of the brain. And she had some symptom relief, but never complete. And unfortunately, in May of 2008, she took her life. Her obituary, the family was very public about her struggle. She was public about her struggle, and they were, but the obituary indicated, and I'll quote it, she was a beautiful, caring, and creative person who fought depression for most of her life. No one tried harder than she did to overcome her illness. However, medications, therapy, and a number of other treatments were never effective for her. Okay, let me go back and give you another timeline that brings things together. TMS is an outgrowth of MRI technology, using a MRI strength magnet to create an electromagnetic pulse. An electrophysiologist named Tony Barker in Wales in 1985 took that technology, created a single pulse system that created a change. And he and his colleagues in Wales created this system in order to find out what would happen if they stimulated the brain, the brainstem, and so forth. As an outgrowth of that, other people started looking at this technology, and a group of people at Emory and Georgia Tech created a MRI strength magnet that could create this type of pulse. Some years later, a group of people out of, well, they were organized in Pennsylvania, but Stan Miller and some other people created the company that took that technology in the context of looking at depression and what could it do. And so they created a team of people that then propelled that into some research. And then if you'll go to the next slide, in 2008, it was TMS was cleared to treat depression that had not responded to a previous course of antidepressant medication. And from that point, TMS became something that was, it was in the professional literature. And when it was cleared, I had been following the literature as it would come out. And I had an assumption, and my wife always tells me don't assume anything because I just get in trouble. But I did assume that this would be something that would be done in an academic institution or something like that. And it turned out that it was an outpatient procedure. And I found out at the time Vanderbilt was going through a change in the head of the department and so forth, and they were not going to be pursuing this. So I contacted the people that created this and said, tell me more about this. And in the context of my, at that time, 20-ish years of practice, and seeing people get better with all sorts of modalities of treatment, but also seeing people not get better. I thought, well, let's see if there's a way to make this work. And when I found out it was an outpatient procedure, and it is probably naive of me to say that the death of my patient had nothing to do with this. So with someone who told me about it, who had succumbed to the illness of depression, and never having that opportunity, it was like, well, let's see if we can at least create an opportunity where this could be of benefit. So, and it's not just that one patient who struggled, but if you go to the next slide, I have some ideas about why it's such an issue. When we look at depression and we look at something called presenteeism, which is when we're there, but we're not fully functioning. It's like the athlete that's got an injury and they can't participate as to 100%. A guy named Lepke in Journal of Occupational Medicine in 2009 created this graph, and it comes from his work, but depression is the #1 cause of presenteeism in the country. Also the #1 cause of expense and days off work and hospitalization and so forth for all of these issues. So it becomes important. And then if we recognize that depression is there, it's intrusive and it complicates not just our work life, but in my opinion, our personal life and so forth. We have options, but if you go to the next slide, we can look a bit at the options. And we find that with each treatment that we have, the further it longs in terms of resistance, the worse the efficacy is. And let's go into the next slide. And we also have greater side effects, and we have greater adverse events. And then if you go to the next slide, we'll have another line that'll show us that we have the durability of treatment becomes less as treatment becomes more resistant. So we've got a group of people who have a severe illness. It affects them, it affects our community, it affects their lives and families. And while we have some treatments that are more traditional, the psychotherapy, the medications that can be beneficial, there are people that don't respond. And so what are other options? So let's go to the next slide, please. So we looked at TMS, this thing that came out from the 80s and then on over the next 20 years, and looking at it, how can it be different? What can it do that other things have not been able to do? Or as one of my thoughts are, what it can do to be synergistic with other things. So if we look at what TMS does, in that it creates an electromagnetic field, which then according to Faraday's law, will then cause a reaction in an adjacent tissue. If we think of the brain as the adjacent tissue and we create that electromagnetic field, and we look at the brain, and we know from research and imaging studies that certain parts of the brain are different when people have severe depression, and particularly the dorsolateral left prefrontal cortex. Is there a way to do something with that, with this electromagnetic field? And if we're talking about the left prefrontal cortex, what happens with the rest of the brain, particularly the limbic system? We're learning more during the last several decades about the neural circuitry that's happening in the brain. And we know that there are connections between the different parts of the brain. And we think that some of these parts of the brain are integral to how mood is affected. So let's go to the next slide. And then we have this early study from 2008, Keto in Japan, looked at, this is an accumulation of 12 people who had a course of TMS. And you can see the coil up there, it's pink, and we've got an arrow that says TMS coil. But right under it is the left prefrontal cortex. And in the middle lower one, you can see the left prefrontal cortex lit up, but also deeper structures such as the anterior cingulate gyrus. So what we're seeing is this building information that there are things that we can do that affect superficial structures that then affect deeper structures that then appear to clinically have an effect on the clinical symptomatology, specifically of depression. So you can go to the next slide. When that stimulation happens, what occurs? And what we know to happen is that the pulse magnetic field creates that electromagnetic field. It depolarizes the neurons. It causes an action potential. It releases neurotransmitters at the synapse, and it propagates the signal through the neurocircuitry. So that's what happens immediately at the site of the stimulation. So let's go to the next slide, and we'll talk about then what happens after that. And all of this stuff is, in my opinion, less provable because it's hard to get complete data. But at the bottom, you can see this list of people and their the research and what we believe happens with the brain at this point is a number of things. There are blood flow changes, there are neurotransmitter changes. I happen to think the most important ones are the plasticity actions. The long-term potentiation that seems to develop with TMS, the repetitive, and when we talk about TMS clinically, I should be specific, it's RTMS or repetitive TMS, as opposed to that single pulse that Tony Barker did. This is an accumulation of pulses over time. And it also changes the neural circuitry by repetitively stimulating. The brain circuits grow, they get more active. And let's go to the next slide. We'll talk about the procedure a little bit, just to give you some context. I know some of you have worked with people who have had TMS, but for everybody, just some sense of exactly what happens in the whole clinical process. It requires an evaluation. You want to diagnose, does somebody have depression? And there are other things that TMS can do. Depression is the one that got the early FDA clearance. There now, by the way, are a couple of other indications. One of them is for OCD with certain systems and smoking cessation. And there will be some other things that the FDA will be receiving within the month, a couple of indications, one of them specifically for generalized anxiety disorder. But if somebody has diagnosis of depression, the way I approach it with people is I kind of go over the pros and cons of their treatment that they've had and different options, and TMS being one of those options, and go over those pros and cons, which the cons are limited, thank goodness. It's got a great safety profile over the years. There is a risk of seizure activity anytime we stimulate the brain. With this system, it's less than 0.0003%, so it's a very low risk. Some other systems have other risk profiles than the one that we use. And if somebody decides they want to have TMS, we proceed on with the treatment. The initial treatment, we find the location that we're going to treat and the amount of energy we're going to use, because those are variables that everybody's a little bit different with. The protocol that we use is 20 to 30 treatments. Each treatment has 3,000 pulses, takes 18 minutes and 45 seconds currently. There are a couple of other profile or ways to do it that have either longer or shorter. And we're learning more about those as time goes on. The treatment itself is a matter of 4 seconds of pulsing and 11 seconds of rest. That's for the brain to rest, but also for the magnet to rest. In the old days, before they had air-cooled systems on these magnets, people would actually put them in water between treatments and during treatments so that they would cool off, because the magnets do get warm after a while. It is an outpatient procedure. People drive to it, and either home, to the gym, to work, to school, wherever they want to go. There are no systemic side effects that such as the ones that can occur with antidepressant medications. So let's move to the next one. A little bit of background on the research that led to the FDA clearance, but also leads us to where we are today. There were two pivotal studies. One, the biological psychiatry study, was an industry study. So as I tell people, you want to pay very close attention to that one. The one on the right was an NIMH funded study that Mark George did. But they looked at things very similarly. And while the archives one was not published until after the FDA clearance, it was the information within it was available as the FDA looked at things. And what it found was that over 50% of people would respond, and over a third of the people would have remission with depression, which is pretty significant when you're taking, in this particular study, on average, there were people that had not responded to 4 different antidepressants. On average, they had a high, moderate, severe depression, but it did incorporate moderate and severe depression, according to the rating scales. Next slide, please. Then a few years later, there was another study that was an naturalistic study, so there was no randomized controlled aspect to it, but it looked at 42 sites around the country, over 300 patients, and looked at the acute treatment, but also then looked at what happened over 52 weeks, over a year. So it was a long-term outcome study. The next slide, please. And in that case, approaching 60% of people had a response, and over a third of people, approaching 40%, had remission at the end of the treatment, and that was 20 to 30 treatments. And interestingly, it broke it down into the low and the high resistance, and didn't make any difference. They were very similar. The next slide, please. And this was one that was extremely compelling, at least to me and to many other people. But when you look at the 12-month data, and I will say we started out 307 patients. At the end of a year, there were only 257 patients. Anybody that's done any long-term research, it's really hard to keep people coming somewhere to do anything over the course of of a long period of time. So there were fewer people, but it had a 60% plus percent of people were maintaining their response, and over a third retained their remission, which is pretty good data, again, with that severity of illness. The next slide, please. Then the other next thing I wanted to mention to you about studies is one that came out and was published in Journal of Affective Disorders last December. It was a paper that looked at a large group of people that is, again, it's naturalistic. It's looking at people that have had TMS and are in a registry database. It's a compliant, HIPAA compliant, de-identified group of people that have agreed to this. And we can look at a large group of people, and there were over 7,000 participants in this, and almost 4,000 people. And now there are over 4,000, but at the time there were almost 4,000 people who had TMS under the protocol. They had a diagnosis of depression. They were treated 20 to 30 times, and they had rating scales that we could look at. And in this particular group, the response rate was almost 70%, and the remission rate was over 35%. That's the largest data set of depression treatment that we have in any treatment modality. And there's been another paper that we've come up with, and there'll be several more out of that same group of people, and it's growing because we continually get more volume with that. And so it's a pretty powerful data set. And next slide, please. As I mentioned, when this all first started, I was dependent upon getting papers when I would get the American Journal of Psychiatry or Clinical Psychiatry and see what was in it. And that would be the occasional paper. In 2019, in the field of brain stimulation, there were almost 1,500 papers published. It's impossible to keep up with that. But what it tells me is that this area of looking at how we can affect things with brain stimulation is growing. And there's now a clinical TMS Society that was started, I guess about 10 years ago now. We recently had one of our annual meetings, and which was exciting to be live with other people. One of our own in the community, Michelle Cochran, is a past president of that organization, and it's been very interesting to be involved and engaged in that. But one of the things that I find when we go to those meetings and hear the proceedings from that is there are variables with TMS, and we're always looking at, if only say 70% of people respond, or approximately 70, what about the other folks? And what can help, instead of some people not continuing to stay well, what can we do to improve what's going on? And the areas that we can look at are the location of the stimulation. The left dorsolateral prefrontal cortex was the area that we found by imaging to have the most connection with depression. And so that has been part of the protocol. But we know that there are other locations that might be integral. The Human Cytochrome Project up at Harvard has been looking at a lot of things, but among them, what are the entry points that to get to the brain to affect these areas that we think have to do with mood? And so the location can be important, and we're doing more research to find that. The frequency is important, whether it's high frequency, low frequency. There is some evidence that low frequency on the right side, left dorsolateral prefrontal cortex, may be just as effective. In Europe, they tend to do that more than they do the high frequency left side. So there are those variables. The amount of pulses per treatment. One of the issues early on in TMS was that nobody knew exactly what to do. And as I mentioned, there are 3,000 pulses in the protocol we use within each treatment. Well, they started out using 100 pulses. They found it to be safe, but then it built from there. And then over time, the research showed that what we're doing seems to have more validity than less, but is more better. There's now a study showing TMS using a total of 10 treatments a day may be effective, as opposed to once a day. That's a lot more pulses and so forth. The coil design can be important. There are several different coil designs. There are now, I think, 7 or 8, I think it's 8 different systems that are out there to choose from now. Most of them have the same coil design. A couple of them are a little different. And then there's the intensity of the pulses. How intense should they be in order to accomplish the goal that we have? So those are the things that we're looking at to see if we can have better results, more sustained results, and find other opportunities of affecting neurological issues as well as psychiatric. Next slide, please. A couple of things that have to do specifically with the work in psychotherapy I thought would be of interest to bring up. This is one that Dr. Siddiqui did some research and published earlier this year, which was just kind of interesting, specifically looking at TMS and the borderline personality disorder group of people. And what it found was it is equally effective. The numbers, there were, this used the quids to look at it, but the severity of depression was higher in the group of people that had borderline personality disorder, but the trend is still there. The quids going from 22 to 13 through the course of treatment for those without borderline personality disorder, it went from 19 to 10. So both positive responses, but the bigger point is that this has come up sometimes in talking with folks is, if somebody has a significant personality disorder, is this still something that can be beneficial? I promise you it won't change the personality disorder, but it can help the depressive symptoms. Next slide, please. I then wanted to talk to you about some research that, and getting to that addendum to the spoiler alert, that a colleague of mine, Martijn Arns in the Netherlands, has done a lot of work with TMS, and particularly TMS and psychotherapy. We can go to the next slide. This is kind of a setup for the next thing I'm going to talk about, but I think it's important. It's a meta-analysis of looking at multiple papers of looking at psychotherapy and brain imaging, and using functional MRI, SPECT scan, and PET scans when people have psychotherapy, what happens. And taking a look at this large number of things, Marwood and Associates found that there were actually changes in the brain imaging. And what they found were changes in the anterior cingulate, the inferior frontal gyrus, and the insula. All of those same areas that now we know that antidepressants affect, when research has been done with brain imaging with those, that they affects the anterior cingulate, the amygdala, the thalamus, the prefrontal cortex. And we know from earlier slides that I mentioned to you that, or showed you, that TMS also has some direct effect on those areas of the brain. Now, how the interplay with all of that is not real clear. How much increases activity, how much decreases activity, because different areas of the brain seem to respond differently to all of these interventions. And then if we can go to the next slide, we'll look at some specific studies that Dr. Arns did, looking at a combination of TMS and cognitive behavior therapy. And this was published in Brain Stimulation actually a few years ago. But what it looked at is the combination of having TMS and at the same time having somebody use cognitive behavioral approaches with that individual. And when this was done, the treatment itself was about 40 minutes. So it was a little bit longer than the 18 minutes that we currently use. But in that particular study, it found that 66% of people responded, 56% had remission. Those numbers are much larger than the open label studies that have been used for TMS with Linda Carpenter, Dan Bloomberger, and Dr. Fitzgerald in Australia. So, and Bloomberger's in Canada, Linda's up at Butler University in Rhode Island, where they generally found that the response is 50 to 58 in this case. And with the combination of psychotherapy, it appears to be significantly different in a 10% improvement. So what we learn is that there is a benefit from having the combination of approaches. Now, the why of that, I think, is worthy of discussion. I happen to think that depression has multiple factors that may well be genetic, that may well be neurophysiological, that certainly are experiential. We know that people that have experienced trauma of various sorts as a child have higher percentages of depression. We know that people in life circumstances that they're dealing with have significant depression. And so that combination of things is, are we helping in some ways, helping some of the symptomatology, and in some ways then helping people learn better coping skills, deal with things better. When about 10 years ago, Mark Dimitrek, who is the medical director of the company that created NeuroNet, the NeuroStar system, came to town, and we had a conversation with the folks at TennCare about adding TMS to what they offered. And I had in my conversation with Dr. Dimitrek, I mentioned, and we've been doing TMS for about a year, and it became apparent to me that after TMS, people were better psychotherapy patients. And he indicated that in his work with a lot of people, he had found that to be the case too. And now, as part of our discussion with the Clinical TMS Society, that comes up frequently. It's my own belief that what is happening is the TMS does something uniquely different. I think it has to do with the circuitry activation. But what I found is that people cope better. They deal with issues better. Over the 11 years I've been doing this, there are numerous examples. It could be as simple as the cat not coming back at night, and until you find him in the morning, you're worried about it. And people telling me they're less worried. Or another example is somebody's house burned down and how they dealt with it. But also the feedback that people are more engaged in working on things, which then leads them to be able to engage in the process of psychotherapy better. And whether it's problem solving, dealing with relationships, or as we just completed a treatment with a lady that she has 3 children, and one of them's 10 years old, and she, on her last treatment, she brought the 10-year-old with her. A lot of people will bring family members or so forth so they can sit with them during the treatment. And as I was talking to the patient and asking her how she's doing, the 10-year-old looked at me and said, "She's not grumpy anymore." And I see that, one, as a positive for that particular family. It's consistent with things that I've heard before, but I think it tells me that someone is modulating their emotions in a way that they are better able to cope with the stresses of life. And as they're able to do that, it gives, I think, a better ability to do a lot of things, including problem solving in whatever area is, including relationships, but also their own past issues that they might be struggling with. So next slide, please. So the addendum to the spoiler alert is that a combination of TMS and psychotherapy is notably better than either alone. And this slide looks at the comparison of, on the far left, there's psychotherapy as monotherapy and psychotherapy with antidepressants. And in those particular studies, there were people that had not treatment or refractory depression, but they were treatment naive. That was the first effort at treatment that they had. Then we look at the situation with the STAR-D, which are the middle four bars there. And the STAR-D was published in 2006, and it looks at a series of treatment processes for depression, and it had about 3,000 people in it in this study. The first antidepressant happened to be Celexa. That was chosen more randomly, not for any particular reason. If they failed citalopram, then they went to a different antidepressant and cognitive behavior therapy. And then it went to a different, if they didn't respond to that, went to a different one. If they didn't respond to that, there was a combination of two different antidepressants and augmentation. And you look at that, and that serially with each step of that, people would decline. They also end up having more side effects, but they would not very many people would, by the time you got to the fourth antidepressant combination or psychotherapy, then people would not be responding very well. And with TMS on the far right, you've got a group of people who have, to get there, they've already failed the four medicines. And so you're really comparing it with a more treatment resistant group of people. So the idea that most of us have is that treatment, or that TMS belongs in that category of when people haven't responded to the more traditional initial approaches, TMS is something that we ought to consider. And particularly when you add it into a psychotherapeutic activity. So I will stop there, and perhaps there are questions.
Okay. Let's see.
And I do have a question when you're ready for them.
Second, guys, I'm going to stop sharing my screen.
Mhm.
Can everyone see the chat box? Can everyone hear me, first of all?
Yes.
Yes.
Okay. If you have a question, you can type it in the chat box. Can everyone see the chat box on your right-hand side? You don't have to type your question in the chat box. Well, I guess in this format, since there's not just a huge crowd, we can just ask your question for.
Okay. I've got one, if it's okay. One thing I was wondering, are there any ramifications for this in terms of folks that deal with dementia or Alzheimer's? I mean, I know those dementia and Alzheimer's has to do with plaque and tau. I think I'm saying it right, TAU. But because it's a brain disease and you're talking about stimulation, that's what made me wonder, could it help at all?
I'll tell you what we know, and there is some preliminary data that's positive, and it gets back to the variables that we can use with TMS. There was a study out of Tel Aviv where they did used TMS, and it was a double magnet, so they were treating both sides at one time. And in that particular study, slowing down the progression of dementia was as positive when TMS was used as when Aricept was used. Okay, so that's one thing. Now, in my own experience, when I was involved with geriatrics for a long time, and so I had a fairly large group of people in my practice, some of whom had depression, some of whom had some degree of cognitive decline, and even dementia. And what we treated their depression with TMS, and their cognitive issues actually tend to get better.
Doesn't surprise me.
I'm not going to suggest that it's treating the dementia per se, but it seems to improve cognitive functioning. There were two interesting studies, one at Beth Israel Hospital in Boston, one at Northwestern University, in Northwestern Hospital. And they looked at normal college students. I'm not sure what a normal college student is. They were basically volunteers that did this. And they had a course of TMS. And what they both different, this was not the same study, these were two different studies, but both of the studies showed that the only thing that was mentioned was improved memory and improved creativity for a short period of time. So it didn't do anything adverse, but that was something that both found. So it is my belief that by stimulating the frontal cortex in this manner, we're creating an improved cognitive environment. Ultimately, what difference that will make with dementia, we don't know yet, but it's something people are looking at.
Thank you.
Scott, there's a couple of questions. One about TMS with ketamine treatment.
Okay.
Betty asked that question.
That's a great question because many of us are looking at that. When ketamine first came out and became available, it was one of those things that, is it something that could be done since TMS, and I should say this, people tend to respond 20 to 30 treatments into the treatment. I'm sorry, 20 to 25 treatments into it. It's a bell curve, and so sometimes it's earlier, sometimes it's later, but it does not have that initial positive effect. So what about using ketamine and TMS at the same time? We don't have the answer for that because the study hasn't been done. There are more and more practitioners that are doing combinations of that. And it's very tempting to get into that, but we don't have enough data to give anything specific about what would happen, but it's very appealing to think about.
If you were to see so the ketamine seems to have that very quick effect,
Correct.
but it doesn't necessarily last. Who knows? Would if it was to be done sequentially, do you have any thoughts about which to try first, or it's just a hard thing to even?
That question.
There's no data, right?
And we were all kind of going, oh, people have ideas. Some of it may be a practical issue. For example, even though TMS is more broadly covered by insurance, ketamine or S-ketamine Spravato is less broadly covered. Sometimes it's that, but from a pure clinical standpoint, it's almost a matter of for example, somebody that has a job, they need to go to work every day. S-ketamine or ketamine is not practical because on those days, you're not going to be able to do it. So TMS practically might be a better option, even though it takes a little longer, it lets somebody function. I will also say we've treated people with combinations of this before. There are some of the ketamine providers around. Currently, it's interesting to me how things circle back, but McLean Hospital, I talked about it earlier, that's where this lady first heard of TMS. They referred me someone who were started treating this week. And they just left Boston last week. They were being treated there with a combination of ketamine and TMS, and they wanted us to continue after it had 13 as of the end of last week, and it wanted us to continue the course of treatment with TMS, and a local ketamine provider is doing that. So we are, I guess most of us that do this are going to have more experience with the combination as time goes on. So it's an interesting question.
Scott, I think you kind of touched on the insurance issue a little bit, but Ruth, I think, followed up with that she had a client who did receive TMS, and it was a challenge to get insurance to approve it. And I think she was wanting to know if that's any better now.
It is better. Initially, there was no insurance. It's a process. I've learned a lot about things I never even wanted to know about that are peripheral to the clinical stuff. But insurance, it is covered now by all the major insurance companies. We continue to battle them. The FDA indication is after one failed antidepressant. Some of the insurance companies have been slow to respond in terms of creating what's a reasonable course or reasonable criteria. Medicare was one of the earlier ones, and they had a requirement of having severe depression, 4 antidepressant failures, and a course of psychotherapy. Blue Cross Blue Shield was one of the most egregious, my word, egregious. They required severe depression, 4 antidepressants, 2 augmentations, and a course of psychotherapy. They recently, some of us, including Michelle and I, have been fairly aggressive with the insurance companies trying to get them to be what we think is more reasonable. And Blue Cross, after we wrote them a very long, detailed letter, said that we didn't provide them with any valuable information, but they changed it to be consistent with Medicare, so they got rid of their augmentation. Within the last month, Medicare has indicated they're changing theirs to 2 antidepressants instead of 4. The reality in this world is that most of the insurance companies follow Medicare in what they do. Some of their 13 Medicare jurisdictions, 2 of them have 1 antidepressant, have just like the FDA indication. All of them are probably moving to that. It's just a glacier speed movement. And so it is easier now to get coverage with the insurance, but they have different requirements in whether it's severity of depression, number of antidepressants, and now they're getting into some even details of what was the specific psychotherapy that was done, because they're wanting it to be quote unquote evidence-based and rating scales used and so forth. So we're not through with the problems with insurance, but it is getting better.
Okay, Scott, Jim asked a question about after the course of TMS treatment, how well is the remission sustained beyond the year that was mentioned? And do you need periodic booster treatments? And then kind of tying into that is Yvonne asked, how often do clients typically receive course of treatments, like weekly, or so maybe you can address both of those together.
Treatments are once a day, 5 days a week for 6 weeks. So 30 treatments is a course of treatment. Beyond a year, we don't have any research data. We have a lot of data in that group of thousands of people. We'll be able to look at that too and see when people come back for treatment. But our experience is that most people that come back for treatment do that within the first year. And when people come back for treatment, they typically need fewer treatments than they did the first time. But a very positive thing is if somebody comes back for a retreatment, there's a 95% chance they're going to respond again. So there's, and we've had, this is a very atypical scenario. We've had one patient who has had 10 treatments in the last 10 years. She had previously been on 12 antidepressants, was at the time I saw her was on a monoamine oxidase inhibitor. She had had ECT and none of those had worked. Every time we use the PHQ-9 among other things, and the highest score on that is 27. She is usually, when she gets sick, she's a 26 or 27, and she goes down to a 2 or a 1 every time. And it's just, I can't explain exactly why, but this treatment works for her. That is unusual to have yearly treatment. But so when, in our experience in over the 11 years, about 20% of our patients have come back to us for a treatment. Some of them may have moved out of town or something like that, so we don't have records on everybody. But about 20% come back, and most of the time they need fewer treatments than they did originally.
And then Kelly asked 2 questions. Is the stimulation individualized with your system, or is it the same across this patient population? For example, I've heard of QEEG being used. And please address use of TMS for PTSD. Any studies that point to benefits, and have you used it for this or anything other than MDD?
Okay. Using it for other things, yes, we've used it for, let me back up. Most of it has been depression with a comorbid issue. We've treated a lot of people that have a diagnosis of post-traumatic stress. There are studies that are positive for treating simply PTSD and not depression. And it seems to be very positive. In our experience, it decreases flashbacks and decreases the anxiety and fearfulness, as well as depressive symptoms. We've also treated bipolar depression, and it works very well with bipolar depression. That is another, both of those things are on the cusp of getting to the FDA The research is not quite there. Adolescent depression is another one. In the studies that were done, it works, but also sham treatment works. So they're trying to work out some of those issues. And what was the first part of the question? I'm sorry,
Is the stimulation individualized with your system, or is it the same across the patient population?
Yes, it is individualized. There is a protocol where we're targeting a certain part of it, but it is not, but everybody's different. The amount of energy required to cause an action potential is different. That's called a motor threshold determination. And that we do for each person, and it's different. The location is different because the skull is different, the brain's different, we're all a little different. There is some interesting research about using the ability to stimulate the ACC, the anterior cingulate gyrus, which then causes a deceleration in heart rate. And we have, we've worked with Martin Arns on that to create a way to find that might be a more effective specific location. You mentioned the QEEG. That's a very intriguing thing, and there's been some research on that. The problem we have is that we have not yet been able to tie in a specific profile with exactly how to do things differently with an individual, but it's part of that discussion that we have.
All right, it is right at 1 o'clock, so we have time for, I'm going to take one more question. Linda asked if there are any contraindications, like i.e. who should not get TMS?
The contraindications are metal in your head that's ferromagnetic, aneurysm, stents, coils, cochlear implants are the things that we're concerned about. It may not be any problem with that, but you don't want to take any chance with that, and nobody's going to do any research on that. Dental work doesn't count, and anything that's within 30 centimeters is what we're concerned about. So things that are further than that are not a concern. You look at some of the things in the insurance protocols, and they'll say that things like pacemakers or pain stimulators are contraindications. They're not. They might be to them, but they're clinically not a contraindication. The only absolute contraindications are the metal in the head that might move if a magnet gets to it.
All right. Well, Scott, thank you so much.
Yes, Scott, really, really appreciate you presenting today. Fabulous information, and I learned a lot. I don't know about anybody else, but thank you so much.
Yeah. Thank you. This was very helpful.